Hi guys, Dr. Gillard here again. It is week 5, it's Thursday. This is part 1. I'm definitely splitting this into 2 parts. We're talking about other causes of pernicious anemia today. Beside autoimmune, we talked a lot extensively about autoimmune related pernicious anemia. But there are other causes of it, as we'll see. And then we're going to get into some stomach problems, dyspepsia. That's the spring of 2021, not the springth. I don't know where that's. My dragon naturally speaking did that. And off we go. So other causes of pernicious anemia are vitamin B12 deficiencies, probably a better word for that. Sometimes these are called type B pernicious anemias. I think of it as B for bug. And it's not always a bug, but it's pernicious anemia that's not caused by an autoimmune attack. And it's this specific one, this type B pernicious anemia, is a bug. It's caused by chronic H. pylori infection. And specifically, and we'll look at this probably next week, chronic whole stomach infection with HP causes a condition called atrophic multifocal gastritis, which is a fancy word for saying an inflammation of the stomach secondary to this bug that has taken over the entire stomach. And so what? Well, the chronic HP infection and the inflammation associated with it destroys the fundus glands, including the parietal cells. So bottom line, and the chief cells as well. It destroys the whole parietal gland. And so you can't make hydrochloric acid, so you have hypochlorhydria or decreased HCl. You could say hypochlorhydria as well, or achlorhydria means, remember we've talked about that. Decreased pepsinogen and decreased intrinsic factor. HIP, right? That's the hipster. And because it typically affects, HP typically starts out, I'm saying typically a lot, aren't I? HP usually starts out in the antrum of the stomach, and it can stimulate and irritate the G cells in the pyloric glands to oversecrete gastrin, which drives acid, so you get an overproduction of acid. But as the infection goes on for years and years, HP can take over the entire stomach, and the inflammation again destroys all the stomach glands. So you switch from an overproduction of acid to an underproduction of acid in all these juices, pepsinogen, intrinsic factor, gastrin as well. If you do, and here there's a lot of, I ask a lot of questions about what are the findings, the gastric juice findings on endoscopy, or what are the blood work in these patients. So someone with type B pernicious anemia, you won't find any antibodies. Type 1, 2, or 3, there won't be any antibodies against the stomach or against intrinsic factor or CBAM receptors. You will find decreased serum levels of vitamin B12. Well, how come? It's not attacking B12. Well, you need intrinsic factor and you need hydrochloric acid to absorb B12, as we've talked about extensively. So you'll have decreased levels of B12, and therefore you'll have findings of hypoblastic anemia or megaloblastic anemia, which we talked about as well. Immature red blood cells, poikilocytosis, oversized, overelabulated, everything we've talked about before. All right. Another type of pernicious anemia is congenital pernicious anemia. Sometimes this one is called intrinsic factor deficiency. And this is kind of a weird one because it's a gene mutation that goes into there's a mutation in the gene that creates intrinsic factor in the fundus glands. And so without intrinsic factor, you can't absorb B12 and you get pernicious anemia, which of course is a subcategory of megaloblastic anemia. So you get megaloblastic anemia or pernicious anemia. They're both really the same thing. It's kind of weird though. Most of the research talks about congenital pernicious anemia is specifically being intrinsic factor gene mutations. But it's weird because there are other gene mutations in, for example, proton pumps right? If the proton pumps can't work, you can't make acid, you can't reabsorb vitamin B12 either. But for whatever reason, they're not. Some authors do and some authors don't. But they're not always classified in congenital. So if you see congenital pernicious anemia, think intrinsic factor. It's a mutation with intrinsic factor. Right? So these patients as well, though they don't have any autoantibodies, it's not an autoinflammatory disease. Stomach biopsy will find no bugs. There's no HP. But they'll still have findings for pernicious anemia, right? And vitamin B12 deficiency, and they'll have megaloblastic anemia. What about the juices of the stomach? Those will all be normal, because this is not a problem with the machinery that makes acid, right? So all the acid will be fine. They just don't have intrinsic factor is the problem here. And the stomach will be fine. There will be no autoimmune related inflammation of the stomach as well. Right, now this is another weird one. This is a lot of subcategories for malabsorptive pernicious anemia. So as the word implies, it means that you're not absorbing vitamin B12 correctly. And we'll look at all the subconditions here. So many conditions can do this, from hepatocrine problems to distal ileum problems. And these are collectively called MPAs, or malabsorptive pernicious anemia. And the first one's that weird one I talked about. Proton pump mutations. There are proton pump mutations. If they're from birth, if you're born with a proton pump mutation, this should really be categorized as congenital pernicious anemia, because it's no different than having a mutation in the gene that makes intrinsic factor. Because either one of those, if you have a mutation in either one of those, you won't be able to absorb vitamin B12. And we talked about that mechanism. So yeah, if your hydrogen potassium pump is messed up, though, you will have different stomach findings. You'll have hypochlorhydria or achlorhydria, meaning no hydrochloric acid. So there'll be no B12 absorption. And remember how that mechanism works, no B12. What's hydrochloric acid got to do with vitamin B12 absorption? Remember that important lecture? Hydrochloric acid is needed to cleave the tail off of pepsinogen to make pepsin. And then you need pepsin to break the food-binding protein off of B12, so it gives hepatocrine a chance to bind to it. Remember, hepatocrine takes vitamin B12 by the hand, and they leave the stomach together, and then hepatocrine gets knocked off by the pancreatic proteases, so intrinsic factor can bind. That's really important that you know that story. Although I guess I'm helping nutrition out a little bit, but it's important to understand that. So what are the findings? The juice findings. If you take a sample of gastric juice and blood, well, they'll have hypergastrinemia. They'll have hypochlorhydria or achlorhydria. Right? I guess I said they have hypogastrinemia twice. Got it? So no HCl equals no absorption, protein pump. Therefore, they're going to have hypochlorhydria. Therefore, there's nothing turning off gastrin. So G cells are always secreting gastrin. All right. Pancreatic insufficiencies. Another one. If you can't make the pancreatic proteases, who are they? You should know that from physiology. That's trypsinogen and chymotrypsinogen. You need those also to reabsorb or to absorb vitamin B12 in the distal ileums. How does that system work? Well, we need those pancreatic proteases to break hepatocrine off of vitamin B12. And once hepatocrine's broken off, intrinsic factor can come in and bind. Intrinsic factor will take B12 all the way down to the distal ileum, where it will be absorbed by cubolin receptors, aka CBAM receptors. How does the stomach look? How will the stomach look with this? So there'll be no hypergastrinemia, no hyperchlorhydria. Everything will be normal, because there's nothing wrong with the stomach juices. There's nothing irritating the stomach. Distal ileal disease is another malabsorptive form of pernicious anemia. So got nothing to do with an autoimmune attack. There's no mutations going on in the stomach. The stomach is working just fine. The pancreas is working just fine. But now the problem is with some other disease that loves to affect the distal ileum. Remember we said vitamin B12 is absorbed through the distal ileum via cubolin receptors, aka CBAM receptors. One disease that loves to strike the distal ileum is Crohn's disease. And it's a inflammation. We'll look at it specifically. It's a full intestinal wall thickness, wicked inflammation, and it irritates the epithelial cells so much that they just can't make cubolin receptors. The cubolin receptors, the CBAM receptors, get destroyed. So they let vitamin B12 and intrinsic factor go right on by. So you don't absorb it. So again, the stomach juices are fine. There'll be normal, I could say normal chlorhydria or normal, right? I could say that. Normal means normal. Normal chlorhydria. Yep, all that stuff is working. Parasites, Cestota, specifically a tapeworm that lives in the ileum. It loves B12. B12 is like candy for it. So it can eat that and absorb it. And it's still considered a malabsorptive, pernicious anemia. What were the stomach juices? There's nothing wrong with the stomach or the pancreas. So all those juices will be completely normal. All right, so now let's get to the disorders. This is typically a hard area that we're getting into here when we get to the gastropathies especially. So disorders of the stomach, nearly 1/3 of all healthcare spending is secondary to gastrointestinal morbidity or problems with the GI system. It's a very, very common thing. You try to get into a GI doc here. Even my own GI doc I've had at Stanford for years and years. It takes me 6 months to get in with him. If you're a new patient, probably 8 to 9 months. The baby boomers having all sorts of trouble with their GI system. So yeah, I completely believe that number. It is a frequent cause of significant morbidity. I mean, you can't eat with some of these conditions. Inflammatory disease and cancers, they love the GI system. In fact, gastric carcinoma is the 3rd most common cause of cancer death in the world. It's a big problem. We talked about what's that node that swells up. That's a sign of gastric carcinoma, which I'm going to test you on Wednesday. Virchow's node, right? Or Trousseur's node, it's AKA for it. Or left supraclavicular node. Dyspepsia, that's an upset tummy. But there's a whole cluster of symptoms when you really question the patient about what do you mean your tummy's upset. There's a cluster of these symptoms that we're going to talk about. Another AKA for dyspepsia is the dyspepsia symptom complex, and it is one of the most common complaints that healthcare providers run into. Dyspepsia means difficult digestion. Doesn't always. It may have something to do during eating, but doesn't always. Sometimes it occurs way after a meal. Any given day, about 28% of the general population has dyspeptic symptoms on a daily or at least monthly basis. That's a huge number. 28% of the population has trouble at least once a week or at least once a month with dyspeptic symptoms. That's kind of weird, isn't it? Daily/monthly. It's got to be one of those. I'm going to get rid of that daily. So a minority of these actually go to medical care. A lot of times if you just wait out your GI symptoms, it could take a year. GI symptoms takes a long time to get better. If you flare something up, it can take a couple years. When people have dyspepsia, usually it ticks 2 of the symptoms. There's 8 symptoms that make up tummy pain or dyspepsia. So usually 2 of the 8 or so the patient has. Interestingly, about 50% of people who suffer dyspepsia it will mysteriously go away with or without treatment. But again, the problem, it could take years for this to happen. Yeah, there's two types of dyspepsia, organic and functional dyspepsia. And the clinical dyspepsia symptom complex. So these are the different specific symptoms that invoke the diagnosis of dyspepsia. There's 8 of them, which we'll look at here in a second. Therefore, this cluster of symptoms has been called the clinical dyspepsia symptom complex. It's really designed more for functional dyspepsia than anything else. That was because more people have functional dyspepsia. You got to know this slide. I guarantee you a couple questions are coming. These are the complexes. So if you have one of these, you get the diagnosis of dyspepsia. And oftentimes, most people have more than 1, 2, or 3 of these. Unusual to have all of these symptoms. So the most common one is something, let me check to make sure. Yep, our fullness is the most common. Yeah, this is the most common, hands down. Bothersome postprandial. What's that mean, postprandial? That means after a meal. Bothersome postprandial fullness. And what does that mean? So that means that if you eat a normal size meal, not an overeat, not undereat, just a normal size meal, it hurts. You have stomach symptoms. You have tummy pain. And that's common in about 90% of people with dyspepsia. That's the complaint that they complain about. So therefore, they have to eat tiny little meals, and they start losing weight. Number 2, and these aren't in specific order. We'll look at the order, but it's bothersome postprandial fullness. This is the most common sign of dyspepsia. Stomach bloating. The stomach feels puffy. Epigastric pain. Maybe it's down. That's xiphoid pain. So that's another complaint down by the xiphoid process. Nausea. Early satiation is interesting, and that kind of has to do with number 1. So these people don't have any appetite. They eat just 1 or 2 bites and they're full. So no appetite after a few bites. And it's probably because they've trained themselves not to eat very much, because in fear of having stomach upset, of having dyspepsia after eating a normal sized meal. Burping is a problem. Epigastric burning is another problem. And why they separate these two, they are specific findings. Pain versus burning are 2 specific different findings. You think they'd lump them together, but they don't. And I double checked that in the research too. And then vomiting. Right? So the 2 most common are bloating and postprandial fullness. And then pain from any area, epigastric pain is next. And then nausea, early satiation, belching, epigastric burning, and then vomiting. That's the official order. That was a huge study of 647 patients, so it's a good study. Organic versus functional. So there's 2 types of dyspepsia. There's organic dyspepsia. That means that you know what the problem is, and you can see it on endoscopy or histology. 30% of people who go to the GI doc, they can find a problem. Functional dyspepsia, they can't. You can't find a problem. 70% of the patients who go to a GI doc and get worked up, they can't find what's the matter with them. And therefore, they're classified as functional dyspeptics. They're functional dyspepsia. This would be a great chiropractic study. In fact, I was going to have one done. Got permission from the deans and everything. And my Stanford GI doc was all excited about this because he's had some very good findings with chiropractic care in some of these functional dyspepsia patients already. You can ask me about it and I'll tell you more about it. But then the COVID hit and it just knocked the wind out of the sail. But I think it'd be a great study. There are chiropractic studies on organic dyspepsia, but there's today, last time I checked, there's 0 on functional dyspepsia because most chiropractors probably don't realize there's a difference between these 2. Organic dyspepsia means we know the problem. So what causes organic dyspepsia? The dreaded gastropathies, or the gastritises. One of these should be gastritises because they're kind of AKs for each other. Counts for about 50% of people who have dyspepsia, and they find a cause. It's because of one of these stomach conditions, usually HP related. GERD is another common cause. GERD symptoms, although it's usually sternum pain, it can be down lower in the epigastrial region. You can have a burning down there and not on the sternum, and that would invoke the diagnosis of GERD. So GERD symptoms can overlap. About 20% of dyspeptic patients have that. Peptic ulcer disease, where you get a hole in your stomach lining from acid. About 7, that can cause stomach pain. 7% have that. And then some bad ones, about 1% of people who go to a GI doc for stomach pain, for dyspepsia, they end up having stomach cancer. That's a pretty high number, I think. I mean, 1 out of 100. I think that's high. It's not like Marfan's. Pancreatic problems can also mimic or can invoke some of those, the functional dyspeptic simplex or symptom complex. So pancreatitis is common. Pancreatic cancer, they can both do it. Biliary tract disorders like cholithiasis or biliary colic can be mistaken for dyspepsia. The common bile duct can refer pain to the xiphoid region, and it can be confused with other problems. You guys know what biliary colic is? So remember this from gross 2 days. You can have a gallbladder. There's the neck of the gallbladder. If you get a stone stuck anywhere in the gallbladder neck, my daughter had one of these. Both daughters within a year had their gallbladders taken out. They both had cholecystitis from stones. You can get a stone stuck down here, and what's going to happen, remember from physiology, that bile is pushed through this tubular system by peristaltic waves. If you get a stone that gets stuck here, you're going to get a hyperperistalsis above to try to push that stone through, and that hurts. It's a crescendo where the pain ramps up and it's killing you. Think you're going to die, and then the pain backs off and lets you breathe. And then the pain comes again. That's a crescendo, decrescendo type of pain. That's also called colicky pain. So yeah, that's what cholithiasis is. All right. How about some more causes of organic dyspepsia? Gastroenteritis, caused by a parasite. You go down to the equator to do some work, and you get a bug, and you have tummy pain, and for months and can't figure it out, and they finally isolate a parasite. Other bacteria can do it. Fungus, syphilis, viruses, the norovirus. Inflammatory disorders can cause tummy upset or organic dyspepsia, like Crohn's disease and its brother, celiac disease. Or not its brother, its brother's ulcerative colitis. Celiac disease stands alone. Sarcoidosis, lymphocytic gastritis, eosinophilic gastroenteritis. They can all cause tummy pain. Here's some less common ones. Oh, there's Mr. Spock is like, oh, I didn't know that. I didn't know that myocardial infarction can cause stomach pain, but some people, the only symptom they get, especially older people, is stomach pain. Thyroid disease, and this is autoimmune related. It's probably Hashimoto's disease, because how does that work? If you have thyroid disease, how does that manifest in the stomach? It's probably because you're also got autoimmune attack of the stomach. Same with Addison's disease, that's autoimmune related. And hyperparathyroidism, gastroparesis, where stomach motility is all messed up, and acute myocardial infarction we just talked about. Pregnancy, definitely tummy pain, right? Morning sickness. Renal failure, lymphoma, amyloidosis, gastric volvulus, where the stomach gets tangled on its moorings. And mesenteric ischemia, usually from an embolism that blocks the superior mesenteric artery or inferior mesenteric artery. There are food triggers that cause tummy pain. The same ones that trigger GERD we've talked about, the spicy foods, the chocolate, peppers, tomato-based sauce, citric fruits, alcohol. all are irritants. Medications, COX-1 inhibitors. 20% of the people who take them end up with stomach pain. And they can cause full-blown PUD, peptic ulcer disease, in about 10% of them. COX-2 is much easier. We talk a lot about how COX-2 inhibitors can spare the stomach. They don't, because COX-1 is the one that's mainly responsible for making the gastric mucosal barrier. COX-2 doesn't target COX-1 inhibitors. COX-2 is present in the mucosal cells of the stomach as well, and long-term use of them, COX-2 inhibitor or COX-2 enzymes can help with the gastric mucosal barrier in some people, and therefore some people can get tummy problems when COX-2 inhibitors or where the COX-2 enzyme is wiped out in mucosal cells. Aspirin, iron supplements, narcotics, classic causes. Antibiotics are notorious for causing stomach upset. Digitalis, digoxin, super common for heart failure, serious arrhythmias. One of the side effects is tummy pain, is dyspepsia. Estrogen, levodopa for Parkinson's patients. The list goes on, but those are the most common. All right, functional dyspepsia. Let's take a look at that one now. Much more common than organic dyspepsia. No organic cause can be found in this type. Remember, we said 70% of people go into the GI doc. He can't figure out what's the matter with them. They get labeled tummy pain as functional dyspepsia. And yep, we looked at the 8 symptoms already. Oh, no, we didn't look at these yet. There are some thoughts about what is causing this pain. So these are the proposed ideas. Oh, I see what happened here. So these are the dyspeptic symptom complex. I'm not going to repeat that list, but it's that same list. Postprandial, fullness, burping. That same list applies to functional dyspepsia as well as congenital or organic dyspepsia. But there are some proposed causes. So they're not strong enough to really kick the diagnosis over to a kind of organic dyspepsia, but they're very strong evidence with some of these. So we'll look at some of these. Psychological disorders. Delayed gastric emptying is a very common one. Impaired gastric accommodation. Hypersensitivity to gastric distension. Altered duodenal sensitivity to acid or lipid. Abnormal intestinal motility, central nervous system dysfunction. We're just going to look at some choice ones here. Psychological stress is a big trigger. This has been known for a long time. Divorce, death of a loved one, loss of a job. You know the deal. And yeah, it can trigger stomach upset, possibly through overproduction of acid, because we know stress does stimulate the release of acetylcholine, which drives acid secretion out of the parietal cell. Somatoform disorders, I've always learned it as somatization disorder or somatic symptom disorder is another common, it's been around forever, psychological factor that can cause tummy pain as well as low back pain. And these patients feel real pain and disability, but they can't find anything wrong with them. Other psychological risk factors, a history of sexual, physical, or emotional abuse. The person affected could manifest with stomach pain. Keeping all that inside of them, they need to talk to a therapist. Anxiety disorder, depression, people with depression, these people all have increased risks. So many, my coaching service where I talk to patients, so many of them have concomitant stomach problems. I always ask that, do they have stomach problems? Probably from the stress of having chronic pain. Delayed gastric emptying. So this occurs when the stomach takes too long to process food. You eat a meal, it should be completely, every trace of it should be gone within 6 hours. These people with delayed gastric emptying, which I have, so I know all about this, it can take 10, 12, 13, 14 hours to completely empty, depending on how much food you put in it. So that's well known, associated with stomach pain. About 35% of patients with functional dyspepsia, if you put them into the lab and test the speed of their emptying, 35% of them actually have actually have delayed gastric emptying, laboratory confirmed, and the range is up to 50% in some studies. Sensitivity and specificity for that aren't the greatest, meaning that some people have delayed gastric emptying, yet they don't have any tummy pain. Like, I don't really have any tummy pain. Usually, if I flare up my GERD, I have pain, but I really don't have dyspepsia, but I have really slow gastric emptying. Impaired accommodation to a meal. So about 40% of people with functional dyspepsia have that. What does that mean? Remember, accommodation, the stomach, digesting food is not easy. It's a complex neurological phenomenon. The distal esophagus, like the pyloric region, grinds the food up and goes under powerful contractions to smash up the food. That's the distal stomach. The proximal stomach, up by the fundus in the cardiac region, that has to relax while the distal region is grinding and compressing the food up. So it's easier said than done. And some people in the laboratory, they find that the fundus in the cardiac region in the body, the whole stomach is grinding at once. And not only can you squirt food back up into your esophagus and cause GERD, the grinding, the over-grinding can kind of wear out the stomach and irritate the stomach and be a source of pain. That's everything I said about the stomach, how that works. Impaired accommodation. So yeah, that's what I just said. The proximal stomach fails to relax and stretch out to receive the ground up food. And you can have some really, really high pressures. Those pressures are thought to trigger nociceptors or even stretch receptors in the stomach wall and cause pain. Endoscopic evaluation would be normal because the problem is with overpressurized grinding of the food, which stimulates nociceptors in the stomach wall. Distension hypersensitivity, what's that about? Stomach can't stand to be stretched. So if you overstretch your stomach, like if you have a normal, or let's say you just overeat, your stomach stretches. Normally people just say, oh, my tummy's full. These people, it hurts. It stimulates the nociceptors. So their nociceptors are overactive where they shouldn't be. This is thought to be one of the major causes of functional dyspepsia right here. They have visceral hypersensitivity. Abnormal sense of pain, we just said that. So yeah, so they just have an abnormal sense of pain with food touching their stomach, almost like allodynia, where people, they can't even put on a sock. Their skin just is on fire. You can't even touch these people. So these people, you can't have anything in their stomach. It sets off pain and stretch receptors when it shouldn't be doing that. Distension hypersensitivity, that's what we're still talking about. Just, you can put them in the lab and you can put a balloon in their stomach and blow up the stomach so it stretches the stomach a little bit, and it sets off pain in these patients way too early. And you can take volunteers who don't have stomach pain and you can blow their stomach way up and they don't have any pain. So they're just, somehow they become sensitized, very similar to chronic pain. Their afferents have become hypersensitive and they trigger the signal of pain way, way too easily. Could be a problem with the visceral afferents themselves. Maybe there's too many of them. Maybe there's too much substance P. There's too much pain transmitters within them. Or maybe it's a problem with the CNS, where it's similar to central sensitization type phenomena, where the brain has gotten so good at feeling pain, it feels too much pain. There's the pancreas to remind you what that looks like. I think we're going to talk about duodenal acid sensitivity. Some other research has found that some people can't tolerate any acid getting in their duodenum, and so their duodenum or duodenum, tomatoes, acid in the duodenum sets off pain when it shouldn't. And again, they've done normal volunteers, and you can inject acid into their duodenums or duodenums, and nothing happens. And you just take someone with dyspepsia and inject a tiny bit in there to have terrible pain. So they're just too sensitive to acid. How do they get acid? Some people have loose pyloric sphincters, and they just drain too much acid. And some people have impaired bicarbonate ion secretion from Brunner's glands, which is super important to neutralize acid, because normally acid, the chyme is going to be acidic. So what's the treatment for functional dyspepsia? It's really hard. Just assure them that they don't have cancer. At least everything is great. It'll get better with time. They can start psychotherapy. Maybe take some antidepressants if needed, and then just eat small meals. Don't eat the dangerous foods. Let the stomach heal. Go on a bland diet. Avoid all these foods until the stomach heals, and then slowly start to come back into these other foods. Acid needs to be turned off because acid can be irritating it. Maybe it's GERD that's causing the stomach pain. Maybe it's a new or a pre-stomach ulcer. Shut off the acid. Use Tums. Use H2 blockers. Use PPIs. There is a drug that coats and binds to ulcers and pre-ulcers called let's look at it like Sucralfate. Sucralfate is a drug that works pretty good. It's prescription though. Misoprostol, prokinetic drugs, which makes those work good. Same for the esophagus. They work good, but all the good ones are banned because of cancer or increased chance of cardiovascular events. And there's the receptors. The H2 blockers really aren't that good. Proton pump inhibitors are the key. A real big meta-analysis demonstrated they did H2 blockers and PPIs against placebo H2 blockers and PPIs, and even the H2 blockers were better than the placebo. PPIs were way better than the placebo for people who had dyspepsia or GERD. Maybe you have to work them up. The people with tummy pain, maybe they have HP, and they need that double course of antibiotics to wipe that out. And that's well supported even by the stingy Cochrane meta-analysis, is support the use of wiping out, eradicating HP. And I've already talked about the gastrin connection with HP. Okay, that's part 1. That's enough for now. Stay tuned for part 2. Hi guys, it's part 2 of our lecture on Thursday, week 5, spring of 2021. Let's talk about the gastritises, or it's more officially called the Gastropathies, or Gastritides is another word for it. Gastritides, Gastropathies, or gastritises. These are all stomach lining conditions, but this is how you'll see them on boards. We're collectively talking about a bunch of conditions that cause chronic stomach inflammation and dyspepsia, which is stomach pain. We talked about that last time. Yeah, the experts in the field have created a terrible mess with this, as you'll see. You thought there's a lot of AKAs in embryology. Wait till you see some of these. Rubens and Robbins need to get together. Everybody needs to get on the same page with this, because it makes it really hard for students and professors to teach this stuff. So in 1994, all the experts, the world experts, all the GI docs and surgeons got together and tried to straighten this mess out. That's a long time ago, and it's still a mess. But I really like this classification system. For goodness sakes, Robbins and Rubens, please adopt this system to make things easier. I don't know why, and there's no excuse for them not to adopt this system. But yeah, they don't. But I'm going to teach you this correct system, and I'll show you the AKAs for Robbins and Rubens. So the chronic gastritis, chronic gastropathies. I like the word gastropathy better, because not all of these stomach conditions, the acute stomach conditions, don't have anything to do with the chronic inflammation, so it's really not good to call them chronic gastritis. It's better to call them chronic gastropathies, but nevertheless, they still call them chronic gastritis. That's my pet peeve with that. Anyway, these are more common than the acute gastritis conditions. It's thought about 50% of the world's population is affected with one of these chronic gastropathies. And they can be completely symptomatic, but that's a problem because they can lead to cancer. You could have a smoldering HP infection and not even know it. And it could end up causing the cells to become dysplastic and then morph into cancer from there. It may lead to some other conditions, peptic ulcer disease, gastric hyperplastic polyps. I took that whole section out because we just don't have time to cover everything. And yeah, and stomach cancer. Yep, horrible mess, as we said already. And what a mess. Clean it up, guys. Come on. Let's take the way that the world experts classify this since the 90s. So meet the Sydney updated classification systems. Nice and simple. So they break it down into 3 types of chronic gastritis. There is non-atrophic gastritis. As the word says, it doesn't cause the atrophy of the stomach. There's atrophic gastritis, which causes histological atrophy. I mean, the stomach's not going to... Well, sometimes it can physically change appearance, but typically they mean you're getting cell destruction more on the microscopic level. But so we have non-atrophic, atrophic, and then the special forms of gastritis. And this is where they lump all the more rare types of gastritis here. We're only going to talk about the chemical induced ones, but there's inflammation that's lymphocytic heavy. There's radiation therapy causes gastritis, non-infection granulomatous, eosinophilic associated an inflammation that's heavy in eosinophils. And there's even other rare ones as well. We just don't have time to talk about all these. We're just going to talk about the big ones. So let's get into them. So again, 3 main categories for this updated Sydney classification system for the gastritises. Non-atrophic gastritis, atrophic gastritis, which has 2 subcategories, and special forms of gastritis. Let's get into it. Non-atrophic gastritis. This is the first main categories we just said. Has no subcategories. Has a ridiculous amount of AKAs. You ready for this? Oh my goodness. And how in the world are we going to make do this? Here's Rubens and Robbins. Robbins is pretty much on the same with Rubens on these things. The key with non-atrophic gastritis, make a note card. What is non-atrophic gastritis? The key, H. pylori infection. It's a H. pylori infection that only attacks the antral region of the stomach, right? So it's an antral predominant HP infection. And that said, most of these AKAs you can figure out if you know that a non-atrophic gastritis is caused by an initial HP infection, and it can stay that way for years and years. The bug can eventually take over the whole stomach, though, and it can destroy. We'll talk about that in a bit, but the initial infection usually hits the pyloric region of the stomach. Therefore, let's look at these AKAs. H. pyloric associated gastritis, AKA for non-atrophic gastritis, HP gastritis, H. pylori gastritis, acute HP infectious gastritis, superficial antral gastritis. Now there's no HP anymore, but we know that the HP affects the antrum. So that's going to be a non-atrophic gastritis. Antral gastritis, chronic antral gastritis, etc. Do I need to go on and on and on? You can read these. The kind of the fly in the ointment here are these old AKAs, which still are around. Robbins and Rubens both use these as well. Type B gastritis. So type B gastritis is bug. B for bug, right? Remember that. Type A, we'll talk about type A. This is type B for bug-associated gastritis, is how I remember that. And these are really rare as I was digging through all the literature when I put this presentation together. There's other AKAs, but those are more rare. I wouldn't worry about those. All right, so MAS, so make sure you know antrum, pyloric, non-atrophic type B, and that'll get you the correct answer for the board question. Shame on Robbins for this one. So why is it terrible, and Rubens as well, why is it terrible to call this HP gastritis, or H. pylori gastritis? Why is that a bad name? Because as we'll learn, HP can cause non-atrophic gastritis, but in the long run, it can cause atrophic gastritis. It can take over the entire stomach. And so HP is a member of both categories, atrophic gastritis and non-atrophic gastritis. That's why it's not a good idea to call it HP gastritis, because which one do they mean? Do they mean atrophic or non-atrophic? So come on, guys. What is it anyway? We said this. It's a chronic inflammation that affects only the antral region of the stomach. It's not a wicked destructive inflammation, at least for the first few years. But the inflammation is more irritative to the cells, specifically the pyloric glands. And we know who the star of the show is in pyloric glands. Those are the G cells. So the inflammation is going to stimulate the G cells to overproduce their product, which is the hormone gastrin. And we know that gastrin circulates through the blood, and it drives parietal cells to produce acid via ECL cells and release of histamine, and directly binding to parietal cells as well. See how important that stuff is, that physiology stuff is? I assume you know that stuff. What is the cause? It's a HP infection. It starts in the antral region. And it is the most common form of both acute and a chronic gastritis. So HP always has to be tested for and eradicated if you find it, because chronically it can lead to cancer. What are the patient's symptoms going to be? Well, if they have too much gastrin and the parietal cells are not destroyed and working, you're going to have way too much acid production. So you'll have hyperchlorhydria. And the hyperchlorhydria is going to cause dyspepsia, upset tummy, right? Hyperchlorhydria is going to cause peptic ulcer disease. It could eat a hole in the stomach. We haven't talked about that yet, but we will next week. You might even get some hematemesis or some melena, some bleeding from this. And yeah, GERD, of course. If you have too much acid in your stomach, it's more easy to develop GERD, and get retrosternal chest pain could be a symptom. It's a very important slide. But sometimes patients just don't have any symptoms. It's just like, how come some people have bigger disc herniations, they have no pain at all? Some people aren't born with nociceptors, or they're born with very few nociceptors and they just don't feel the pain, which can be a bad thing, because as I said, this can convert into cancer in the long term. Epidemiology is crazy off the hook on this non-atrophic gastritis. A really big kind of famous study done back in 2015 by the Veteran Affairs Council shows 80% of patients who were having an upper GI study for dyspepsia, 80% of them had HP after the biopsy. That's crazy. And then some authors and studies say that the prevalence, they're not huge studies, but some studies have found 100% prevalence over the age of 70, where your immune system just isn't powerful as it used to be. How do you make the diagnosis? Well, you have to take histological sampling. You can't see this with the naked eye. And you can, under the microscope, you can see the bacteria hanging out in the antral region of the stomach. And the fundic region of the stomach has to be spared. The inflammation is there. There's inflammatory cells there, but it's not a destructive type of inflammation, at least at first. What causes the PUD and GERD? We already could have taken this slide out. But remember that the HP stimulates the pyloric glands in the antral region, and the antral G cells release gastrin like crazy. So you get hypergastrinemia, And gastrocnemia drives ECL cells to make histamine, and histamine binds to parietal cells and stimulates HCl. And then gastrin has receptors on parietal cells and binds and stimulates directly the release. So it's a double stimulating mechanism. Okay, and then we remember this, just a little review. There's HP causing an inflammation and irritating the G cells. G cells get mad, and some cells stop working when they get mad. Some cells oversecrete stuff when they get mad. And in this case, the infection is not bad enough to destroy. It just makes them mad, and they release gastrin. Gastrin stimulates ECL cells, releases histamine, and binds to its H2 receptors. And parietal cells, that causes the release of hydrogen ion. I'm going fast because I've covered this a million times. I can hear, oh, slow down, you're going too fast. No, you should already know this. Gastrin also directly binds with CCK2. All right, more sequelae. In addition to PUD and GERD, what else can the hyperchlorhydria do? It can get into the duodenum and start to cause trouble. Remember, the duodenum is not designed to take tons of acid. So the extra acid can start to inflame the tissue of the duodenum and cause the tissue to morph into a different type. It can even become dysplastic. Interestingly, and dysplasia can lead to cancer. So the acid irritation can lead to cancer. Interestingly, the metaplasia, the duodenal cells, which is simple columnar with goblet cells for the mucus, they can morph into stomach cells, which don't have goblet cells. They're still simple columnar, but there's no goblet cells. There's no microvilli either. They're stomach cells, and even stomach glands can pop up that can then become troublesome because they can secrete acid themselves. And then we can have some far downstream ulcers from over acid production of this new metaplastic tissue in the duodenum. Duodenal bulb is particularly susceptible, and that thing I was just talking about, you can call that gastronized. The duodenum can become gastronized by chronic acid exposure. That's my word, but it's a good word because the esophagus becomes intestinalized, and metaplasia occurs where the esophagus gets intestinal tissue. So why can't we call this gastronized? And as I said, the intestinal simple columnar morphs into stomach lining epithelium, complete with funded glands, and even pyloric glands. Goblet cells are lost. And those new stomach glands can overproduce acid like crazy in the intestine, which leads to downstream ulcers and severe peptic ulcer disease. And to make things worse, we know H. pylori loves stomach tissue, and it can actually migrate from the stomach into the duodenum. So that's crazy. How do you treat this? You got to kill the bug. And no, you don't take anti-inflammatories, right? The COX-1 inhibitors or even COX-2 inhibitors are irritative to the stomach, so that will worsen the problem. You have to kill the bug. So double antibiotic therapy. I had a whole 5 slides on that. I took that out a while back. You can Google that and look at the exact type, but it's a double antibiotic therapy is what is recommended. And then you have to do follow-up testing to make sure you killed the bug. For the acid, in the meantime, you should be taking proton pump inhibitors to shut down the acid, and H2 blockers really doesn't help that much, but you can take them anyway, especially at night for breakthrough acid. And endoscopic monitoring, look for cancer. And you can take acetaminophen painkillers and run that by your primary healthcare provider first, but you can take acetaminophen for that, but no NSAIDs, no COX-1 or COX-2 inhibitors. Interestingly, some fun facts, about 25% of patients who have dyspepsia, even after the HP is eradicated, they still have pain. And that's got to do with the brain and increased sensitivity and central sensitization. And it's very common with chronic pain patients. When you finally fix the problem, the pain continues because they've become sensitized. They've gotten really good at feeling pain. Just like riding a bike when you're a kid. You get really good at it, and you could I haven't ridden a bike for, well, I ride a stationary bike, but I haven't ridden a real bike for, geez, since I blew my disc out, probably back in 2002. I haven't ridden a bike. I guarantee you I could jump on a bike and ride it because I've got really good at doing that. All right, spontaneous regression. This is another weird thing. About 10% of the cases, if you just do nothing, the HP will just die off, and we don't exactly know why that happens. It's only in about 10% of cases. The trouble is it can take years, so you can suffer for years until that happens. Okay, the atrophic gastritides. That's gastritis. Another AKA is the gastritides or gastritides. Let's look at them now. So atrophic, we just looked at non-atrophic was just one category. Atrophic actually has two categories. So there's autoimmune, and we're familiar with this one already, and atrophic or multifocal atrophic gastritis. This is HP bacteria again mainly. There's some weirdness with this. We'll save the next time to talk about that. But let's look at atrophic gastritis. So atrophy causes stomach atrophy. Not really visible atrophy until the very late stages, but it causes more histological change. There's two subdivisions, as we said, autoimmune atrophic gastritis and multifocal atrophic gastritis. We'll get into that next time. Let's look at autoimmune atrophic gastritis. Oh my gosh, come on, authors. What a just ridiculous mess. But nevertheless, here's the mess. So autoimmune atrophic gastritis, anything with the word autoimmune is going to give it away, meaning that this is one of the Sydney classifications, atrophic gastritis. Diffuse, Robbins calls it diffuse atrophic gastritis. Chronic atrophic gastritis. In the same chapter, he calls it two different things. Merck Manual, which is another board book, calls it autoimmune metaplastic atrophic gastritis. At least it's got that atrophic in there. Type A chronic gastritis. So that one you just have to memorize. Remember, B was for bug, so that was non-atrophic gastritis caused by HP. Type A is for autoimmune. Right? That works just nicely. Just like the pernicious anemia is type A and type B pernicious anemia. So this one affects the body of the stomach because it attacks parietal glands. So you get corporal is another key word. So diffuse corporal. Remember, corporal is an AK for body. So diffuse corporal gastritis. Diffuse corporal atrophic gastritis. Pernicious anemia associated gastritis, because it is, I mean, a lot of these patients have pernicious anemia. All right, you get the deal. So the key words are autoimmune, atrophic, corporal, pernicious anemia, and type A. Okay. So autoimmune atrophic gastritis, that's what we're going to call it. It is the subcategory of the main category is atrophic gastritis or gastritides or gastritises. It's a subcategory of that. We know a lot about this because it's very similar to type A pernicious anemia. And what is it? It's an autoimmune attack specifically against the fundic gland or the fundic region of the stomach. It's almost always against proton pumps or other parts of the parietal cells what gets attacked. But it's the fundic glands get destroyed in this condition, and so it destroys parietal cells and eventually the entire fundic gland, and there goes your hipster, right? There goes your hydrochloric acid is gone from the parietal cells, your intrinsic factor is gone, and your pepsinogen is gone from the chief cells. Patient's symptoms are the same. Dyspepsia, they have an upset tummy. Proton pumps are destroyed in this case, so unlike atrophic gastritis, or non-atrophic gastritis, unlike non-atrophic gastritis, who have high amounts of acid, these patients have no acid because the proton pumps are destroyed. and the parietal cells are destroyed. So they have hypochlorhydria or even achlorhydria, meaning no acid. So if you don't have acid, you don't have GERD. So there's no trouble with GERD. There's no trouble with ulcers, peptic ulcer disease. And yeah, so I mean the autoimmune attack can lead to a chronic autoimmune-related inflammation of the body, the anatomical body and fundic regions of the stomach. Remember, there's a difference between anatomists and pathologists and histologists with regard to stomach naming. Histologists would call the anatomical body and fundic regions of the stomach just the fundic region of the stomach, so be careful of that. It spares the antrum. So yeah, why does it spare the antrum? Well, there's no target there. The target is the fundic, is in the fundic gland. It's the parietal cells. So there's no parietal cells in the pyloric region. There's G cells mainly. These patients often go on to develop type A pernicious anemia, which that eventually will become symptomatic. We talked all about that. Some fun facts. Counts for less than 10% of the cases of chronic gastritis, gastritis. Remember that the HP-associated non-atrophic gastritis is far more common. That's the number one, is HP problem. This one's not nearly as common. It targets a couple populations. The Caucasians, especially Caucasians with Scandinavian descent, are hit more heavily. There is a familial connection. There are some genes, which is autosomal recessive. Took all that out because we just don't have time to go into the weeds on this stuff. What about autoantibodies? So 100% of these people are going to have autoantibodies because it's to make the diagnosis of autoimmunotrophic gastritis, we got to find antibodies. And so they will all have, if you don't have an antibody, it's not autoimmune. Okay, so specifically we know what type. Robbins calls these type 3 autoantibodies. So type 3 autoantibodies will be floating around in the bloodstream. You can test for them. What's the sequelae of the autoimmune attack? We already said this. Parietal cells get destroyed. The collateral damage, the chief cells are next door to parietal cells, so they get engulfed. It's like a fire occurring in a condo. There are really no space between the condos. The adjacent condos go into flames as well. Same thing here. So you lose your hipster, right? No hydrochloric acid, no intrinsic factor, no pepsinogen, no intrinsic factor. If you lose your hipster, can you absorb vitamin B12? No way. So you develop pernicious anemia. Specifically, what type of pernicious anemia? Type A pernicious anemia, right? Which is a form of vitamin B12 deficiency, leads to pernicious anemia, which is a subcategory of megaloblastic anemia. We've talked all about that. All right, that's enough for your brains. I will see you all next week. Remember, week 6, we have the CVPP midterm, so you better be busy studying. See you later.